In this piece, we call for equitable expansion of virtual care based on lessons learned from the COVID-19 pandemic. My name is Tafaya Haddad. I am a medical oncologist and associate professor of oncology at Mayo Clinic. I also serve as the medical director for the Mayo Clinic Center for Digital Health Remote Patient Monitoring Program. I'd like to provide a brief overview to our Perspectives and Controversies manuscript entitled Avoiding the Faux Equalizer. We have witnessed unprecedented growth of telehealth and virtual care services during the COVID-19 pandemic. The Mayo Clinic Remote Patient Monitoring, or RPM program, was initially developed to support patients with chronic conditions, and it's been operational since late 2016. We rapidly adapted this program and framework at the onset of the COVID-19 pandemic to support our institutional response to the public health emergency. The goal of the COVID-19 RPM program was to reduce hospital utilization and to keep our patients connected to healthcare resources and care teams while self-isolating during the acute phase and recovery from the illness. To be eligible, patients had to test positive for COVID-19 at a Mayo Clinic site and have one or more risk factors for severe illness. We made sure that there were minimal restrictions to eligibility beyond this, as we wanted the program to be accessible to as many people as possible. So we were serving patients who were not previously seen at Mayo Clinic, and those that the RPM program had not served in the past as well, such as patients who are non-English speaking, those who are pregnant, post-transplant, or actively receiving cancer-directed therapy. The in-home RPM technology was provided by a Mayo Clinic, and knowing the rural nature of many of our Midwest patients, it included a cellular-enabled tablet to help mitigate the risk for patients not having broadband access. The kit also included Bluetooth-enabled medical devices, a blood pressure cuff and monitor, pulse oximeter, and thermometer. And these devices were pre-connected to the tablet to minimize need for digital savviness for setup. The tablet would prompt patients to complete symptom assessments and take their vitals 2 to 4 times daily. And based on pre-configured parameters, the alerts would be triggered when adverse health trends were present, and a team of centralized nurse coordinators would complete clinical assessments in response to alerts. This program was implemented in our first patient enrolled in late March of 2020. And while overall cases were low in the Midwest, as well as our southeastern and southwestern sites in Arizona and Florida at the onset of the pandemic, within 6 weeks, there were outbreaks of COVID-19 occurring at local meatpacking plants in the Midwest. But it wasn't until several weeks later that we were made aware that a substantial proportion of these patients in these communities who were eligible for the RPM program were declining participation, in some cases even providing us with false contact information that we requested so we could ship the technology kit to them. We were devastated by this. We knew that the outbreaks were disproportionately affecting racial and ethnic minority people, especially the Hispanic community and those with limited English proficiency. And research had already emerged at this time that the higher rates of COVID-19 related mortality were experienced by Hispanic and Black people. We had a program that could allow us to closely monitor them and potentially identify adverse health trends early and enable interventions that could alter the disease trajectory and improve clinical outcomes. And yet we didn't understand why patients were declining this valuable resource. In response to this observation, we bolstered our medical interpreter services and made them available to our RPM nurses and our COVID-19 care team partners. We also ensured the technology kit had Spanish language enabled. However, we were very disappointed to learn that other languages were not available. Despite these adjustments, weeks later, there was still low enrollment in this cohort of patients. So our providers engaged with community leaders, and through a series of discussions, it emerged that there was deep cultural mistrust, and many of these patients were declining participation because of the concept of being monitored instilled fear. We postulate that local and national anti-immigrant tension and rhetoric was directly contributing to the low adoption of this program. To address this, we revised our team's script that they utilized when patients were notified of positive test results and offered the opportunity to participate in the program. We aim to establish trust, share the program goals transparently, and introduce them to their care team. We expanded the technology setup instructions and program overview, ensuring both written and oral versions were available in their native language. And while this improved racial ethnic minority enrollment, by the time these gains were made, hundreds of vulnerable patients went without monitoring and support. So this observation is consistent with other publications regarding telehealth utilization, specifically utilization of digital health technology by seniors and by Black and Hispanic Latinx people, regardless of age, were significantly lower than their peers. We share our experience because there is a prevalent misconception that transformative advances in technology can expand communication, dissemination of information, and products and services to all people. And this is the premise for the title of our commentary, Avoiding the Faux Equalizer. I credit my co-author, Dr. Joshua Pritchett, for this title and reference to the creation of the Faux Equalizer concept by Adrienne LaFrance, who is the executive editor of The Atlantic. In her seminal piece, she highlighted that the notion of technology leveling the playing field ignored systematic inequalities. So as we think about technology gains in healthcare, the expansion of telemedicine and virtual care services that are enabling decentralization of care from our hospitals and clinics into the home environment, one would expect that this could serve as a bridge and improve healthcare access to populations that have historically faced disparities and been underserved. In our case, despite our intentional efforts to make the COVID-19 RPM program as accessible as possible, this did not translate to equitable engagement. So if we hope to avoid the consequences of faux equalization for our patients and avoid exacerbating healthcare disparities, it is our responsibility to conscientiously build these technological bridges and to narrow the digital divide. We invite you to read our Perspectives and Controversies piece and to reflect on how you, individually and collectively, can contribute and ensure equitable expansion of virtual care as part of the digital transformation of healthcare. Thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.